what I wanted to do today was talk about several cases that have come to my attention that really presented some interesting challenges in terms of decision-making, management, um, how to handle these. And I think there's some good general lessons, and in several actually, there's application to group health as well as work comp, that some of the situations, the decision making that occurs isn't confined to just work comp, so it's applicable more broadly. So let's look at some of these cases. These have all come, a couple of them were mine, others have come from you all. And so one is denial of physical therapy under future medical care, which actually applies not only to future medical care, but to denial of PT or denial of any other service in an active claim. An ag injury not resolved at season end, and what is some of the decision making that has to occur there vis-a-vis a patient's desire to continue working, if not at that company, then another, and there's some residual symptoms, what happens. We talked once before about concurrent job-related, non-job-related injuries. How do you parse those, and how do those get managed? And then for any of you that have seen Zynex prescriptions, and I've seen half a dozen or more of these now, coming from a company that's got excuse me, physical therapy devices, portable ultrasound, that sort of thing. I'm starting to get, and have been getting periodically, RFAs for my signature for the purchase of these, which I think is something we need to be looking at closely when you see these. I've got some examples of that. And then case on job stress. And then also an interesting situation with a patient had a request for multiple job restrictions with PNS. And how do you decide at that point what are reasonable job restrictions? So we'll talk about these, get into these as far as we can during the course of the hour. Excuse me. So here's one. Andrew, are you with us today? Maybe not. In event. So this is one. A patient worked at a golf course, had a left shoulder injury, 2019, resulting partial rotator cuff tears of the supraspinatus and other parts of the rotator cuff. Did some PT at the time with some improvement, authorized to do more, but did not excuse me, continue the therapy because of COVID, has a history of diabetes, trying to limit exposure to folks, and so didn't get PT. Eventually determined to be MMI, PNS, and excuse me, 2020, the following year, had a recommendation for future medical care, including PT, and the claim was closed with provision for future medical care. So he followed up the following year in May, excuse me, reporting return of left shoulder pain. He had been better, but the pain without new injury was returning. And so the provider asked for physical therapy twice because that had been provided for under future medical care, with 2 denials. And the response, the denial letter, indicated that the notes, the request, the medical notes, didn't show, quote, changes in the facts material to the utilization review decision. As such, the adjuster is not compelled to take any further action upon this request for authorization. Didn't deny it because for some reason they thought that it didn't show a material change that would require physical therapy at that point. And then went on to say, additionally, as this determination is based upon statute, as a typo, not upon medical necessity, the determination is not subject to appeal, reconsideration, or independent medical review. I'm in the process of getting some information about what constitutes a determination based upon statute, because when there's a denial, the denial can either be based on statute or on the absence of medical necessity, which is what we generally see. And when there's a denial based upon statute, then it's technically not appealable for 12 months. although when it's denied under medical necessity, it can be. So the note I got from the provider, it included several updates, which were really quite lengthy and thorough, and documented positive changes. But it excuse me, didn't change the mind of gosh, I'm sorry. Didn't change the mind of at least the adjuster, and presumably there were no options at that point. So what to do at this point? I presume you've seen these letters, and the question is how to go about then these denials, whether they're under future medical care, whether they're an open claim, or what should you do with these things? Well, the first is to take a look at the denial letter, which comes with an application for an independent medical review that's sent to both the patient and the physician typically. The denial letter explains the basis, the thinking on the part of the reviewer regarding the denial, why the denial occurred. And it almost invariably references MTUS, medical treatment utilization schedule. And in fact, generally has 3 or 4 or more pages, single spaced, lengthy pages of explanation quoting MTUS, and sometimes a bit of a challenge to kind of pour through that and figure out what's there. But the basis for the denial then is contained in that letter, and automatically, as mentioned, and these are coming from the adjuster because the denial goes from the UR physician, UR company, to the adjuster, and then will be forwarded to us. And along with the denial letter, there's an application for an independent medical review, which is something that the patient does technically. We don't ask for an IMR. The patient technically asks for an IMR. And so there's a portion of that form that's filled out that is provides some justification on the part of the patient. But there's also a portion there that requires, if this is going to be seriously considered, a statement on our part as to why an IMR should occur, that we feel that there's some basis for that, whether information was that's valuable was not included, or was included and not seen, or seen and not given enough importance. So it's our opportunity to help the patient respond. And these can be expedited. Normally that wouldn't be, in our case, the expedited IMR is generally, excuse me, when there's some sort of acute medical problem that requires immediate attention. That's generally not the case when we're seeing patients, but they can be expedited. And those get sent to the, back to the adjuster. I would note in that I rarely see that non-appeal is mentioned. In other words, that this is done under statute and not medical necessity. So that normally isn't going to be a problem, but you would want to look for that. And then if the denial doesn't recognize medical information, either that, again, we hadn't included, that was there and was not seen or not attended to by the UR person, or there was some material change, the first step, I think, is to call the adjuster and just explain that situation and see what the option is. Every now and then there's a reasonable adjuster, in fact, probably more often than every now and then, that will respond to that. You know that in denials cannot be made by adjusters, but authorization can. The adjuster can authorize anything. The adjuster can't deny anything unless it's what's called a deferral, because the claim's under review. So technically that's not a denial, but what's referred to as a deferral. But otherwise, the adjuster can authorize anything, oftentimes is reluctant to, because it's coverage to have the utilization review physician do it. But I would discuss it first with the adjuster and explain the situation and see what that adjuster recommends. If that doesn't bear fruit, then the next step is going to be submit to the an independent medical review, there's a DWC form IMR that is the form that accompanied the response from the adjuster that comes with the denial letter. And I'd fill that out and send that off. I haven't had a lot of experience in doing those, and I'm not sure how long that takes, and I'm not sure how responsive the IMR physician generally is to this, but that's the next step that should be done. Then, if those first two steps don't work, speaking to the adjuster and responding to the denial, second step being independent medical review, then the third step is really contemplating some other similar but different therapy, maybe chiropractic or acupuncture in lieu of PT, or something that is, again, similar but not the same. Now, the other thing that one would not encourage, it would not discuss with the patient. But of course, if the patient has a new injury, then or aggravates, you recall the chart we've looked at many times, if there's an aggravation of that pre-existing problem, that of course constitutes a new injury, and then the clock starts running again. And one can, on the basis of the new injury, request whatever appropriate treatment, justifying it appropriately, but it's not a matter of going back to future medical care. That isn't something we, again, discuss with a patient. That isn't something we would encourage anywhere. But if there's an aggravation, of course, then the game changes, and whatever therapy that's appropriate and consistent with MTUS can be done. So what I am going to do is, I've got some calls out to find out more about denials under statute and whether, to what extent one can really respond to that, or does one have to wait for the full year that is specified there. One of the places where this occasionally comes up is, I don't know how often you see this, but I get a fair number of patients that come in, this is sort of an aside comment, come in and with whatever musculoskeletal injury, and in the first visit, they're asking when they're going to get their MRI, or they're going to get, generally MRI is what they want to know. Many of the patients that we see are educated about MRIs, or that those exist. And that's one time where I will occasionally bring out to the patient that there is a risk in doing this, requesting it unreasonably too early. The possibility exists that it'll be denied. And if it's a denial under statute, that means, unless we've got some other recourse, that the denial is good for a year. And so I'll tell patients, well, if you want me to request it, I'll do it. But the risk is that if it's denied, then it may be that we can't go back and get it for a year. So that consideration can come into play on occasion. So in any event, when you get the denials in, review the denial letter, look to see what the basis is. If there's something that was missed, misinterpreted, or otherwise not correctly perceived or understood by the reviewer, then call the adjuster. If that doesn't bear fruit, send in the, if you think that it's appropriate, if you really want to get whatever the procedure is, send in the independent, or talk to the patient about filling out their portion, and you provide documentation for the independent medical review. And the third is just some sort of alternate therapy. I don't know. Any of you have any thoughts about that? Any challenges with this in particular, or found a secret way of solving it that would be useful sharing?
Steve, Nick Joy.
Hey, Nick.
I'm a little hard of hearing. Are you saying under stature with an R or statute with a T?
Yeah, there was a typo on my wording there. Statute.
Okay, and what does that imply to us?
Well, the bottom line is when there's a denial decision made on statute, then it can't be appealed for a year. When it's based upon medical necessity, in other words, with medical treatment utilization schedule, which describes what we can do, what has to have happened, what the circumstances need to be to make a convincing case that there's medical necessity for what we're doing, then that can be appealed. But when it's under statute, and I will, once I get some more information about that, when it's under statute, we're not able to appeal it for 12 months. So my apologies that I don't have a full explanation of what statute is. Then I'll have some more about that. The way regs and our guidance is promulgated is when a law is passed by federally or by state, then it's in statute, it's a law. And then appropriate bodies, whether federally or by state, develop ways of implementing the law. They'll develop regulations. So statute is a legislative act, and regulations are an executive act. And most of what we do in MTUS, for example, the content of MTUS was developed, and at least how it's applied was developed under regulation. So those can be appealed, or those that are by medical necessity and described by medical treatment utilization schedule.
But what determines if it's under statute? Do you know?
Well, that's what I need to find out. I'm not sure. I have called several folks, a couple of adjusters, to understand exactly what that means. To be honest, I had not seen that come up until this particular claim. And I don't know what statute describes, but I will get back to everybody once I understand it more.
Yeah, it sounds to me that one of the options is to approach the adjuster and have them explain why they put that denial under statute in simple but explicit terms.
Yes, well, that's right. And one of the adjusters I called didn't know what the answer to that was, and she was going to try and track it down with some of their staff. So this is something seemingly some of the adjusters don't understand, or at least the one I talked to didn't. And what'll happen is it'll come back to them from UR with a description of medical necessities, what the terminology I usually see, but this one response referred to statute, and the UR provider physician referenced that and indicated that it was not an appealable decision. So I will get more information about it and share that. The takeaway right now is, to the extent possible, just be sure you're justifying what it is you request. And we've talked some about medical treatment utilization schedule. It may be useful to review some of that again in the future, but that's where the content is for medical necessity. That's the case we need to make, is that something is medically necessary. Either it's the only medical treatment that's available or appropriate, or there's it's accepted as reasonable treatment, physical therapy for low back, for example, and it's in the course of what we're treating. We're using medications. We've got patient at light work or maybe off work, but generally light work. And physical therapy is a medically acceptable treatment modality. But we can go into that some more detail. The next time around, I'll have more information about what constitutes statute. But for right now, again, when we send in the RFA request for authorization, we just want to be sure in our medical notes that there's some sort of justification, ideally referring to MTUS, but at least some sort of justification for why we want to do whatever it is we're requesting. So let's move on to another one here. Here's an interesting, El Ray, are you on the phone?
I'm here.
Okay, let me just summarize this briefly, Ray, and then maybe just make some comments about what you saw when you talked to the patient. This was just 3 months ago. A patient came for an initial work comp visit, works as a general laborer for a farming company locally, reported while planting vegetables in August of this year, experienced sudden low back pain with numbness, presumably in a leg. I was evaluated at Natividad Medical Center a couple of days later. X-rays were thought to be normal, and diagnosis of lumbar strain and given appropriate medication. And then meds were helping, got drowsy with Flexeril, eventually changed the dose. Pain wasn't any worse, kind of going along 4 out of 10 pain, no other significant symptoms, apparently no radicular symptoms. And she was continued to have low back pain later in the month, unchanged, radiation to the right thigh, some numbness, bending and the squatting made it worse, and had to be cautious in what she was doing. And apparently was off work with no light work. And continued with meds. Order was placed for physical therapy, and then got to the end of the season. Excuse me. And she didn't know if she was working year round or just temporarily. Most of the folks in the field are work on a seasonal basis, and it starts up in March or so and ends in October, November. And she was probably temporary and had sufficient symptoms that she wasn't sure if she was going to be able to work at a new job if she was temporary or going to get benefit. What was the discussion she had with you, Elray, at that point?
You know, I remember the first initial visit. I don't know if I had this. Did I see her on the second, the follow-up? Because I don't remember having this conversation with this specific patient, but I remember a recent one, kind of a similar situation.
Okay.
And in that case, it was recommended talking to the employer in terms of their visa status and if they're part of that.
H2A.
Yes, thank you. But I don't remember specifically for this patient.
Okay. Well, here's the deal with this and other patients. Getting to the end of the season, the first question is, are they able to do regular work or not? And if they're not, then what should happen? And the issue generally for these folks is that they the disability risk stopping. The way adjusters, the work comp carrier manages that piece is if there's evidence, if they can provide evidence that in the off season, they would normally find other work with a different employer, do that other work at other job until the season starts back up again, then the carriers will continue providing disability benefits if they can't do regular work. Either they're totally disabled or partially disabled. If, however, as most workers are, temporary workers, they go back to Mexico or someplace, or they just don't work, or there's some piecemeal work, but they're basically resting or not being as active, then the disability stops. And then the question is, what sort of wage replacement is there? Because presumably with whatever the extent of disability, they can't go find other work because they're partially or totally disabled. And so can't qualify for unemployment. So they have to be looking for work, able to work, looking for work to qualify for unemployment. For SDI, state disability, they're disabled and can't work. And the question is how to go about that. If they're not going to be qualified for SDI because they don't normally work during that time, then there's not going to be continued wage replacement. So the choice is they would qualify for SDI, but not, they can't get unemployment. And are they, should they then say that they're okay, that they can work and try and find another job, but risk making it worse? Or should they just admit that they can't work and see if they're going to be able to get wage replacement from the carrier or not? If not, get it from SDI. And that was the issue for this particular patient. And under these circumstances, what really has to guide it is what's the nature of their problem. If they really can't work, then they should not hold themselves out as able to work and try and get unemployment or find another job. The answer is really SDI for these folks if they're not going to be getting continued wage replacement from the carrier. So we can't tell them what they should be doing, but what we can do is if they're not going to qualify, if the carrier is not going to continue to provide wage replacement, then the answer really is SDI, and we need to be willing to sign those forms. And that was, I believe, how this particular one ended up. So, and as mentioned before, we've talked about this. There's a question, a question with a box to check. If the employee is getting, if it's a job-related injury and has been getting wage replacement or benefits under workers' compensation, we check that box. And the carrier knows then, the state knows to coordinate, EDD knows to coordinate with the carrier to make sure that there's not double dipping going on. So in these season ending situations, we determine with the patient if they're able to return to regular work or not. More often than not, it's a patient decision because they know how they feel, they know what their job is, but we participate in that decision with them. If they can resume regular work, we clear them for regular work. If they can't, then we continue the restrictions, and then it'll be an issue of the patient with the carrier determining if they're going to get continued wage replacement from the work comp carrier, or they'll apply for SDI and get payment that way if they qualify for SDI. So this comes up invariably several times, at the end of the season, October, November, when the temporary work is ending. Any questions about that? Anybody bumped up against this problem before and found?
Yes, Steve,
Yes,
Mick Joy again.
yes,
Uh,
Mick.
I'm a little confused. So if a worker is seasonal, injured and cannot go back to work, but normally doesn't work in the off season, then they wouldn't qualify for the SDI.
They would qualify for SDI, but not workers' compensation under work comp.
Okay, they would still qualify for the SDI.
Right.
Okay,
So, yeah. So that's the first decision is, can they resume regular work or not? And if they can, and we discharge them and we clear them for regular work, they potentially qualify for unemployment because theoretically they're out looking for a job. And that's how they handle it. I believe that there's got to be some evidence that they're doing that, but I'm not an expert in how unemployment works. And if they can't resume their regular work, then the carrier will make a determination as to whether or not they're going to qualify for continued wage replacement. And if that's the case, then that's where income is provided. And if it's not the case, if they don't have evidence that they normally have other gainful employment in the off season, then most of the time they're not going to qualify for continued wage replacement by the carrier, and they'd qualify for SDI. And then they'll bring us those forms to sign. So that's the way we would approach it. Any other questions about that? I have some number at the end of the season that don't work. They leave the country or they just don't work. And then they're not going to continue to get the wage replacement from the carrier. Okay. So here was the question we just discussed. Now, periodically we'll get cases where there are two events that occur on the job, and one seemingly is a non-industrial event, and the other is an industrial event that may or may not be a consequence of the non-industrial event. Bear in mind, making the decision about whether something is job related or not, there needs to be, as we've talked about before, the AOE, COE discussion arising out of employment in the course of employment. There needs to be both a causal and a temporal relationship between the job and the event. So causal, there needs to be something that actually happened on the job, that something related to the job caused the injury or illness, the accident. And then there needs to be a reasonable time frame. So something may reasonably have happened on the job, but if the timing is inappropriate, then there's a denial. So we're making a decision, an AOE, COE decision, and just because something happened during the workday doesn't mean that it's going to be accepted as a job-related problem. Example, appendicitis that begins on the job. Clearly, 99 or greater % of the time, there would not be a relationship between whatever work they're doing and appendicitis. Excuse me. In some cases, hernia. If somebody has a sedentary job, clerical job, there wouldn't necessarily be a relationship between the hernia and work. Heart attack on the job, most of the time is going to be determined non-job related, but there can be mitigating circumstances, stress or whatever, strenuous physical activity. So sometimes, but again, the point is that just because something happened during the 8 or 10 or 12 hours that somebody's working doesn't necessarily mean that it's going to be accepted. And then if there's something that happens on the job that seemingly is non-job related, but an accident may occur, then it's possible to have a job-related component and a non-job related component. And so here's one that I saw last year. Patient worked for about 5 months at a local ag company in sanitation at a packing shed. He walked into an area where several coworkers were active, felt a sense of panic, became dizzy, slightly blurred vision, and then became unconscious, fell to the ground, hitting his head. He was unconscious for an unknown period of time, perhaps 30 minutes, according to the patient. An ambulance was called. During transit to Natividad, he became conscious. He had no antecedent chest pain, shortness of breath, palpitations, or any other suggestive antecedent symptoms. Evaluation in the ED included skull x-rays, no serious injury. He was recommended to be off for a couple of days and then return to regular work. And so he had two things going on. He had the syncopal episode and he had the head injury as a consequence of the fall. Significant information is that he reported he had had similar episodes of dizziness in the past, but not syncope, and that they were occurring a couple of times a year for the past 10 years, but he never lost consciousness, never had a medical evaluation. He opined the cause to be recent poor eating habits, lack of exercise, and subsequent weight gain, but that doesn't seem a reasonable explanation for episodes of dizziness over the past 10 years. So when he came in then several days later, felt well, no further episodes of dizziness, labs was normal, some elevation in triglycerides, HDL was a little low. And so I offered to refer him to a cardiologist on a non-industrial basis, but he demurred. And then I discussed with the employer his return to work, the sort of decision, can somebody return to work safely without really discussing his personal non-industrial medical history. Spoke to the adjuster as well, and the explanation was that they would consider the head trauma to be job related, but that the syncopal episode that preceded the fall to be non-job related. On that basis, I conclude that since he appeared at the last visit on 6/3/21 to have recovered from his head contusion, he would be able to resume regular work. And no more treatment seemingly was needed there. On the other hand, syncopal episodes, non-job related, should be further evaluated. I talked to him more about that. And then he was willing to see a cardiologist, and that my recommendation was that he would remain off work on the basis of this syncopal episode until cardiology consultation had been obtained, and that no serious adverse cardiac conditions were identified. So the work comp claim would be closed because we were dealing just with the head injury. He was evaluated, seemed to have recovered. There wasn't any evidence that he needed any more management of the head injury. But in a separate silo, related but separate silo, the syncopal episode was as yet unexplained. And the issue was this fellow wasn't driving, but on the job. But if he had maybe had an episode in the future where he was at an elevated site and fell off, not just from standing on the floor and hitting his head, but maybe a greater distance, there was some potential risk of more serious injury. And so I felt that he really needed to have cardiology consultation before I cleared him to work on a non-industrial basis. So again, he went to see the cardiologist, and so the issue is then sometimes it's clear that no industrial injury precipitated it. It was non-industrial, but then something happened that would be considered industrial. In a case like this, it was a relatively easy decision to make that the syncopal episode was non-industrial, but the head injury would be accepted by the carrier as industrial. So what we need to be doing is, in situations like this, whether it's syncope or something else that precipitates what would become a job injury, we need to be sure we understand the event. We need to understand the circumstances, what happened on the job, and being able to distinguish between the non-industrial component and the industrial component, and then manage both of those as separate circumstances, as separate situations, one on a non-industrial basis and one on an industrial basis. And in another one coming up in a moment, we have something where that's a little more clear. Any questions about that? Anybody had any of these types of cases? Anything you wonder about in distinguishing, making that AOE, COE decision, whether or not something's job related, or where a portion of it may have been related to work and another portion may not? Okay, well, bear in mind we need to have the opportunity. We need to make that decision on occasion of what portion is job relation, what portion is not job related. Here's Zynex prescriptions. And I've seen several of these recently, and they're invariably a 3-page request with a cover letter from Zynex, who's a company that makes devices for physical therapists. And what they want to be selling is their Zynex Next Wave device with supplies that include whatever is included with that. And I've had several of these where in some cases, initially, there wasn't any justification coming from the physical therapist. I've had one or two actually, where I went to the chart and the medical record, looked back to the physical therapist, and there was no mention of the desirability of an E-stim device, or in the next box down, bracing. And in one case, actually, the patient had already been discharged from physical therapy. And so coming with that's document you're seeing, if you can see it, that's signed presumably by the physical therapist. I guess that's the physical therapist's signature, prescriber, the physical therapist. Then they'll submit also the RFA, request for authorization, with everything printed in, and conveniently my name printed in here, and for my signature at the bottom. If you see these, I'm not saying that this isn't appropriate or that the patient doesn't need this, but I would be attentive to two issues about this. One is I would look back and maybe even call a physical therapist and see if they feel that there's really value in this. The other thing is, on this particular form, the recommendation is, what's the duration? And I've had a couple of these where it was a purchase. And what the risk is then when a claim is resolved is the request may be made on the part of the patient for future medical care to include this device, and then lengthy, maybe lifetime supply of medical supplies on a monthly basis, as you see on this form. So I never sign those, even if the physical therapist does. I always indicate rental, and I'll just specify generally 3 months or 4 months, because if the problem's not going to be solved during that time, there would be a question as to whether or not this is going to really be valuable for a prolonged period of time. So if you see this form coming from Zynex requesting purchase particularly, but even rental for long periods of time, you saw maybe in this box up to 18 months, 3 to 18 months, don't sign those without talking to the physical therapist to make sure that this is appropriate. And if you do, make sure that this is not particularly a lifetime. You see here, length of need, lifetime. Be sure it's not for lifetime. And I wouldn't even do it more than 3 months at a time. So in any event, just be alert to that. I've seen half a dozen of these now recently, and I think that we just need to be cautious about those. So much for that. Now we'll go back to Zynex. Oops. Job stress. We've had a number of these claims come in, and these sometimes are relatively easy to make decisions about and sometimes more difficult. You recall that perhaps that in prior discussions, we've recognized, or the decision about job stress is this, does this meet the criteria in the labor code for job stress, or is it what's referred to as an employment action? And so the criteria typically, most strictly, include for job stress that there's either a specific event that occurred, somebody works in a check cashing company and there's a holdup and there's a threat to a bodily harm, or the patient's beat up on the job by somebody, then that's a specific event. Or if there's discrimination involved on one of the usual bases, which is sexual, gender, ethnicity, or one of the other bases for discrimination. Those two exist in the labor code as part of the definition for job stress. Absent that, most of the remaining are going to be considered employment action, which is really issues of stress on the job that are most appropriately resolved with HR, with talking to people and working out conflict. And every now and then we get some really kind of interesting requests from the patient. And so this came to me. The clinic involved just received this work comp email from the patient with a list of reasons why she's wanting to file the case. The provider wasn't sure how to go about it and was looking for some suggestions. It looked like in reviewing the chart that there was a recent history of suboptimal working relationship between the patient and the supervisor, and the patient offers her recommendations for resolution. And those include the following: not having desk procedures for my job and any policies or procedures to follow. This is my preferred and main way to learn and do my job. Zoom calls being watched or being put on the spot, I freeze up and have other symptoms of stress. Number two, customer service work, especially in areas that I do not know, or talking to multiple people, is not something I can do comfortably or on a regular basis. Number three, dealing with certain supervisors and authority figures causes great anxiety. I need advance warning and what may be discussed in advance. Number four, I need training on any record keeping systems, any other computer programs that I'm not familiar with. One-on-one training by someone I can watch but not be watched by is the way I can learn this. Five, I need written instructions that I can follow and do on my own. This is the way I work and learn new tasks. I have always been that way. Multiple people giving instruction in work direction is confusing. Six, my anxiety is situational, but mainly being put on the spot to perform a task, watched as I work or learn, speaking about anything in a group, trying to learn something new with deadlines are some of my major anxiety causes. Seven, I'm most comfortable with rules and structure. Eight, I'm comfortable when I can work independently with someone I can trust, give me training or information as needed. You mentioned that I should ask my union rep for advice, including her in this email. And then goes on to say, when I took this job, it was explained by my manager, and she names the supervisor. She names both. The anxieties I have when dealing with certain situations and people was, her word, told this would not be an issue. So I have no doubt that there's stress involved in this patient's situation. The question is, does this rise to a level of bona fide job stress as defined in the labor code, or is this really an employment action? And it's significant because although the patient may well need mental health counseling under either circumstance, how this gets handled by the carrier is significant. When there's a bona fide job stress, as I described before, then the carrier will pick that up typically. And some of these are very straightforward. And the patient's typically going to be off work and they'll start receiving wage replacement. The carrier can put these, as you know, on delay for 90 days. During that time, there is no wage replacement. And they look into the case and determine if this is going to meet the criteria for job stress, or is it really just to be defined as employment action, something that really needs to be resolved on the job with HR or the union or some other ideally mediating group and assist in whatever issues need to be resolved. So in a case like this, it seemed to me really pretty clear that unless there's some other stressor on the job than what the patient's describing, this really is going to become an employment action and really needs to be resolved with HR or again, whoever's going to negotiate solutions to this, speak to the involved people and come to some sort of resolution, whatever it might be, reassigning an employee, reassigning a manager or a supervisor, or whatever other thing is going to happen. So I think the approach I take in these is, number one, I take the person off work just because whatever in the end this turns out to be, the person is generally best served by being off the job for a period of time, whatever period of time that might be. The second thing I do is I tell them I'm going to do this, then I tell them that this may well be what's referred to as an employment action. In the end, it may not be accepted as a job-related claim. And third, that the carrier is going to almost invariably put this on delay, and there won't be any disability payments, wage replacement, when the claim's on delay and being evaluated for up to 90 days. And I'll invite the patient then to let me help them figure out the best solution to this. If they would like to see a mental health counselor, I'm happy to make that referral. And during the time that claims on delay, the carrier will pay up to $10,000 for any care we provide, as long as it's consistent with medical treatment utilization schedule. So some number of times we can get them into a mental health counselor and help them deal with the anxiety, whether this ends up being considered job related or not. I make sure that they understand again that they're not going to get paid, and do they feel that they may be better off after a short period of time off work to go back to work and to try and work through this and resume gainful employment, or is that not going to work? And in these situations, when you see a patient, almost invariably, whether it's job stress or almost anything else, you're not getting the whole story of what's happened in the workplace. And it's beneficial to talk to the employer about what's going on and encouraging both sides to get together and try and resolve these. In some occasions, I'll talk to somebody in HR. Sometimes I'll talk to the supervisor, start off with the contact person. We generally know who that is for each employer. So I would have this discussion with the patient and then speak to the employer, talk to the contact person, and try and begin some process of reconciliation. In a case like this, you saw that the patient made no mention of discrimination on any particular basis, but just laid out what the work circumstances would be. Now, if she was promised something that wasn't delivered in the workplace, the situation may change, but there would need to be, I would think, documentation of what she had been promised rather than what her understanding was. But that's something that needs to be worked out in the job. So when you see this kind of situation, I think it's reasonable to take them off work for a short period of time, discuss what's going to happen when the claim's on delay, and what might well end up being the resolution in the end if this is considered an employment action. My own opinion is, as I've mentioned before, I wouldn't try and become the patient's mental health counselor yourself, unless there's indication that they just really need some sort of short-term medication for some reason. But occasionally we follow patients, we get them on longer acting drugs, trying to help them work through their anxiety. I think we're much better off to get a mental health counselor involved in trying to treat these. So any questions about that, distinguishing between bona fide job stress and employment action or management of these? They can be challenging. And the other reason, I think, for not getting too deeply involved in these is the decision for job stress. If it looks like something may well qualify, the criteria is that the patient's aggregate anxiety needs to be at least 51%, however you measure that, 51% due to the job circumstance for it to qualify. Unless there's a specific action, that drops to 35%, 35 to 40%. So that's a difficult thing to determine, and it requires us or somebody rummaging around in their psyche, trying to determine what pre-existing stressors have existed in their life related to the anxiety. And just in most cases, we just don't have the time to do that. So I would take the approach described and again, speak after the patient with the employer and sometimes even the carrier. Okay, let me move on to one other job stress. This was a situation, history of anxiety as a teenager, was on Ativan when she was 16, has not been on medication for many years, denies history of hospitalization or mental health in the past, denies any significant history, legal complaint filed against the employer, reports she believes her supervisor is the main source of her stress, as well as mandatory overtime, long hours, some other difficult things she's seen in the prison. She was working in the prison down in Soledad. Reports feeling overwhelmed, having insomnia due to stress of work, has been off work since the complaint. And this is a little more straightforward in terms of a pre-existing problem. And again, would be managed the same way. Now, the question here would be in part was, what did she know about overtime, long hours, and some other experiences working on the job? Was any of that laid out to her in advance? And then did the circumstances change? That needs to be explored. But again, the situation is that this will be put on delay. Now, the prison, as a state employee and as a prison guard, there are other circumstances related to work that sometimes come to bear in this. And stress as a prison guard can be seen as more reasonably job related than some of the other clerical or other jobs that people are doing when they bring stress claims in. So this may end up being, and this is why you need to be aware of some of the circumstances, and it's worth talking to the employer about it. There may be some mitigating circumstances in some of these cases. So in addition to talking to the patient, talk to the employer and find out what the circumstances are and how they're likely to manage this. And you may again want to talk to the adjuster once the claim's opened to find out how it's going to be managed. So I would talk to the contact person, the adjuster, when you know who it's going to be, and just find out what their perception of circumstances is. So this was a slightly different case of stress, but the approach is generally the same. So